Welcome to the Medical Support to Irregular Warfare podcast, an initiative to discuss and educate the evolution of medical support in peace, security, and conflict in uncommon environments. Points, perspectives, and opinions voiced here are solely those of the contributors and do not represent any formal association or government entity. We do everything possible to ensure the information and discussion is sound, comprehensive, and from the most credible sources. Ladies and gentlemen, welcome to another MSIW video podcast. Today's episode discusses and educates the tactical and operational use of the Global Health Engagement Program in support of your objectives and your engagements at the unit level. The Global Health Engagement Program is a U.S. Department of Defense effort intended to support and serve health engagement between the United States and its allies and partners in both mill-to-mill and military-to-civilian efforts. This organization was formerly called CGHE as a whole. It's now changed in reorganization and part of the National Institute of Defense Health Cooperation. But the impact remains the same. GHE was even once a track at SOMA. But this subject today follows our prior thoughts on medical actors in the IW environment, critical to partner and allied preparation and synergy. Understanding that potential in synergy and partnerships, we hope this episode will assist the tactical medic, the unit-level medical advisor or battalion surgeon, or even an embassy foreign service officer as a tool for employment. A later episode, we hope to help impact command and theater-level engagements of health and defense with GHE as a tool. As we do this, and in my own updated education, it's important to remember that GHE efforts have definitely shifted away from the historical and traditional winning the hearts and minds to being a tangible tool to prepare the operational environment, develop interoperability, and support current and future operations. With that, I'd like to introduce our guest for today, Dr. Ramey Wilson, an internal medicine physician and Henry Jackson Foundation employee, currently the Senior Advisor on Knowledge Management for the NIDHC, as we mentioned before, at the Uniformed Services University. Ramey served for 28 years, beginning his time as a field artillery officer, but then going to med school and serving primarily in the airborne and special forces. Dr. Wilson has been a significant force in America for medical interoperability with international partners and allies, and he is also a member of our own MSIW committee. Ramey, welcome, and thank you for your time, sir.
Oh, thanks, Mike. It's a real honor to get to speak to this community and talk about something that I feel very passionately about. So I'm really excited about this podcast and helping to share kind of what we're trying to do with global health engagement.
I love it, sir. And with that, I'd just like to hit you with a few short questions to break the ice on the subject a little bit, Ramey. Sir, I've read a few of your works, and it is clear that you have a true passion for international health work and partnership. Where does all that stem from?
I think a lot of it started when I was a resident, and as part of my residency, I thought I wanted to be initially an infectious disease doctor because that's where a lot of operational medicine, it seemed like, was focused on. And so when I was a resident, I was fortunate to get to spend a month in Thailand working at our overseas lab there doing malaria research. And during 2 of those weeks, I actually spent time up at one of our surveillance sites along the Thai-Myanmar border and basically, taking care of people and doing surveillance studies of people walking out of the jungle with fever, just trying to identify it. And while I was there, I got to help also provide care to the people in the refugee camps along that border, as well as work at one of the small, austere hospitals that was supported by NGOs, taking care of the people in the refugee camps. And so, it showed me the value of what you can do even in austere locations and the value of medicine and providing those type of services to people that are otherwise disenfranchised and don't have access to care like that. So that's really what got me excited about global health engagement, refugee health, and taking care of large populations from a public health and a clinical perspective.
It sounds like that trip to Thailand had a huge early impact on your entire career.
I really tried to advocate for those type of experiences, especially for our junior medical officers and planners and and the whole idea of global health engagement in general, get people out there to see the value of spreading the good work that we can do as Americans in supporting of other people.
Yeah. Remy, I also see something different and actually quite unique from my perspective for a doctor or physician. You always have been very active, especially in things like PFC, PCC development and protocols. But more importantly, as a physician, you've placed a lot greater emphasis on the development of medical systems, vice therapeutics. Where does that priority come for you?
I think in general, I'm a systems thinker. My undergraduate degree was in human factors engineering with a minor in systems engineering. So, I look at things from a systems perspective and always thinking of like, how can we make this better? How can we make this more resilient? How can we make this more effective? Because I'm never fully satisfied. What I've actually realized is one of my hobbies is to optimize things, like even my personal life or whatever, just because if there's a way to do it better, I'd like to explore that and see if it's worth the investment.
Sir, this is not a surprising discovery by me. I've worked with three doctors with an engineering background, and they all look at systems, medical systems in particular, in a completely different light. So I appreciate that personally, and I respect that a great deal. So thank you. I know you have a short presentation just to provide us some further education. So if you would like to serve that up, sir, please go ahead.
Okay, so this is my presentation, and as any presentation, I've got to give a disclaimer both from the Henry Jackson Foundation as well as USU and our center that what I say is my own perspective. And what you'll see is that my comments aren't necessarily what's covered in doctrine, but you'll see that a lot of it is harmonized and informed by doctrine. So this is hopefully what I'm hoping that over this brief conversation and presentation that you'll get out of it. And this is kind of what to expect. I'll tell you a little bit about our organization. I'll talk about global health engagement in general, how I envision it as a tool for developing interoperability, and why I think interoperability is the better way to think about global health engagement, especially in the MSIW environment, but then also thinking about medical preparation of the operational environment and then knowledge management in general. So global health engagement is now was initially part of the Center for Global Health Engagement. In last year, we actually were established as the National Institute for Defense Health Cooperation, and that merger brought together three actual organizations. The National Center for Disaster Medicine and Public Health, which was a sister center of ours at USU, which is really focused on the homeland and really focused on public health in general. One of their big roles was developing and supporting the integrated CONUS movement plan for casualties coming back to the U.S. So, that unclassified planning factors are 1,000 casualties a day for 100 days. We don't have that many beds in our system. And so how do we integrate in with the National Disaster Medical System hospitals? How do we prepare for that? We're just wrapping up this year the NDMS pilot study, and we have new language in the NDAA from last year, continuing that as the medical surge program of how we would integrate and support NORTHCOM as part of our globalized trauma systems to take care of people from point of injury all the way to rehabilitative care in the US. If you think of the way medicine supports irregular warfare, it really needs to take a whole of society approach. And so, whatever that society or area of unit is, whether it be a state, whether it be a community, a whole of community approach, whole of state approach, whole of nation approach, whole of region approach, and being able to engage it at different levels, I think is going to be very important. And so, the priorities and intents of our center are here in terms of three major capability areas of knowledge, training and education, research and analysis, which would be what I call big R research as well as little R research, which would be more performance improvement and helping doing assessment and monitoring and evaluation of programs in support of the combatant commands, and then planning and partnership, which is kind of where I sit in terms of operational knowledge management, which is how do we support our combatant commands, our services, as well as the interagency space with the either facilitating engagement, having a convening authority to bring together groups together to solve problems, or directly with the combatant commands to tackle some of their issues of working with partners and our allies in an integrated way, right? And the underlying principles there are listed below: partnership, CivMil engagement, and that CivMil is U.S. CivMil, but also CivMil and Civ, 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 all of those kind of ways to work by, with, and through other countries in order to accomplish what it is we want to do. And then this idea of accountability of what's the return on investment? Are we being good partners? our partners being good partners, right? And I think that's a big key theme for global health engagement that I've learned, especially at the tactical operational level, is you need to hold your partners accountable as well as to ourselves, right? In some ways, a key lesson of global health engagement is we can't want it more than our partners. So, to be a partner, they've got to be willing to partner with us. And so let me ask you, Mike, what to you is global health engagement, or why do we do global health engagement?
I'll give a graybeard perspective, at least, sir. Is I think global health engagement probably first serves national interests. And then secondly, I would expect it to help promote morals, values of the United States and our partners. And thirdly, I think I would suspect that it's meant to help develop systems in our partner nations if we would ever have to rely on those medical systems.
Yeah, no, I think that's a great answer, right? And so I kind of like to think of it also as what's the why, how are we going to do it, and what it is that we actually do, right? And so for me, I think the way to think about it, and this is something that I'm trying to get people to think about, is why do we do global health engagement? Well, my answer is at the end of the day, the reason we care and we do global health engagement is the same reason that we have a medical system that supports our warfighters, which is that we value human life. That at the end of the day, people, individuals matter, and that as best as we can, we want to preserve and facilitate health, which is more than just the absence of disease. The WHO defines health as more than just the absence of disease, but this thriving. And so if you think about what that takes, and then you look at the government structures of governments of different states, we believe as Americans that our form of government of liberal democracies are the ones that promote the ideals of life, liberty, and the pursuit of happiness, right? And that it's the best form of government that we know that's better than tyranny and oppression. And so while war sucks and it's terrible, there are going to be times where people need to be willing to fight and defend our way of life and also help others develop a way of life as well. And when people fight, there are casualties. And so not only do we, through global health engagement, help prepare our partners to handle casualties that then demonstrates, right? Because what you do demonstrates what you believe. So if you focus on global health engagement and you focus on decreasing the suffering and the pain and the adverse actions of war as best as we can, and at the same time know that wars are going to be best fought by having effective security forces, because effective security forces will help with deterrence, then actually having good medical systems to support security forces, whether that's the army or your police, are going to help not only with deterrence, but also give them the impetus and the motivation to actually do security operations rather than just avoiding conflict or avoiding getting hurt, which is the same reason why we have a medical system for our military. And so I see doing global health engagement as a good on multiple levels. We're helping support and advocate our beliefs of the value of human life, but also the idea that there are things worth defending. And I think liberty and our way of life is also worth defending for ourselves and for our partners that are trying to provide those same ideals, right? So we can't be it for everybody, but the question is like, why are we in the military different than the WHO or the American Red Cross or the International Red Cross Red Crescent Society? And some of that is the job of the military is to fight and win our nation's wars, and ideally deter wars if possible. And so that means people and our partners, because the American way of war in general is that we fight as part of a coalition. And so the more we can build capability and interoperability with our partners, the better. So that's kind of my approach to it. I think the purpose of GHE, which is outlined in this slide, also kind of talks to this idea, and this comes straight out of this Doty version is about 5 years old, and so this isn't new ideas that Ramey is coming up with. This is actually in our doctrine where it talks about cooperation, preparedness with allies and partners, aligned with our theater support, and where I think we've kind of gone a little astray is that as we've shifted from stability operations to preparing for large scale combat operations, the goal has been a little bit different, right? So in stability operations, it was to help our partners demonstrate essential services and provide services to bolster the validity of the central governments that we were trying to support and grow. Now with large-scale combat operations, at the end of the day, it's one of demonstrating readiness and deterrence. And so what I think is our goal is, as we do global health engagement, we need to think about, can we help our partners get to such a level that we would be okay with them taking care of an American casualty if needed, which really within an MSIW and prolonged field care and what we're expecting and what we're hearing, like from Ukraine and other LISCO environments, is very much a realistic thing. Now, it may be that we can't get them to our normal level, but maybe we can get them to a level that we would be happy with under crisis standards of care, or at least providing care that's better than nothing. And so I think focusing on, what we do with global health engagement, using this definition from the DoD, which is building trust and confidence, sharing information, coordinating activities, and then achieving interoperability. And so there are goals, because medicine is delivered really below the tactical level, at the technical level. And so there's really like thinking about global health engagements at the technical, tactical, operational, and strategic level. Each of those levels have different tasks, have different ideas, different focuses, different goals that, if you're focused on interoperability, are going to be in many ways customized to the person that you want to develop interoperability with. And so that's kind of like the work that we're trying to do to promote that. Now that we're an institute, we're looking at it not only abroad, but in the homeland, within our own, medical system, our own pharmacy systems, our own the disaster medical systems, if we were to have to escalate to total war. And so this is how I think global health engagement can support that. I think that, I like the model that was used during the COVID to talk about infectious disease threats, that used to detect, prevent, and respond kind of methodology. And so the idea is like, how do we know what the risks are? Once we know what the risks, we can decide if we're going to mitigate them or not. We're going to mitigate them either by having capability or developing the capability in our partners through interoperability or through prevention, right? So the example I use a lot of times is malaria. Like we probably will we need to know where malaria is, whether or not we need to be worried about it or not. And we know it's a risk that historically has had significant impact on the disease non-battle injury rates and the readiness of forces abroad. And we're going to mitigate that, hopefully mainly through prevention, through malaria prophylaxis, by, uniform treatment, by spraying areas, decrease the vector living and life cycle, et cetera. But we're never probably ever going to get malaria to zero. Like we're always going to have the ability to diagnose and treat malaria. And so all of these happen together. But what we do know is that the more we can get our partners to also engage in these activities in their areas, then maybe we can rely on them sometimes rather than us having to do it for ourselves everywhere, right? Which then allows us to do more in the same area, or to do more overall across the world. And then there's this idea of interoperability. The idea of interoperability is that if we can get them to do it for themselves, one, we don't need to do it for them, but two, maybe they could do it for us. And so in the middle there, the whole idea of health engagement, especially at the operational and tactical technical level, is kind of listed there, which is thinking about interoperability. And if we think about interoperability as a function of capability and a desire to be interoperable, then we can then break it down, and the activities can then be focused on what we're trying to focus on, right? So if you're working with a partner that is at a lower level of medical capability or technology, then the global health engagements may be focused more on building capacity or expanding that capacity. If we're working with a partner that is maybe one of our NATO partners that has standards of care that are very similar to the US, and they want to be interoperable, now we're just focused on doing it together. And maybe we're doing exercises and demonstrating and refining that interoperability rather than building capability. And so understanding what it is, and I think many ways, I think focusing on interoperability is also the more moral focus, because then it's how do we work together rather than what am I doing for you or what are you doing for me? It's what are we doing together? And I think it also is one where, especially if we were to inject a crisis standards of care paradigm in here, we could also say we're going to focus on developing interoperability, maybe at a level that that we wouldn't normally have, but is better than what they have now, that under crisis standards of care, they could contribute to solutions that to save lives, and not just their lives, but U.S. lives as well. So I think I know this is a busy slide, so I'll give you a second to kind of take a look at it. But I think the value of leveraging and focusing on interoperability for our MSIW is is almost unlimited in terms of kind of what you want to focus on, whether it's going to be information sharing, whether it's going to be exchanges, but understanding that global health engagement is a cross-cultural experience. And so, some people are better at that than others. That is something that we can train people for. But some people, just like, we select people for special operations and that have a certain temperament or skills that are inherent in the same ways, we need to be thinking about what those skills are to help build partnerships, right? And so when I was the SOC Africa surgeon, our kind of motto was medics together are strong. And at the end of the day, most of the easy problems have been solved, right? We're now at a point, I think, in the world where we have a lot of really hard problems, and most of them are going to have to be solved by teams. And so the more people we have looking at these problems and working together, we can maybe actually get after some of these big problems and challenges. And so if you look at it from an MSIW perspective, I'm just going to pull this out of, this kind of initial article that was in Special Warfare that kind of talked about the resistance operating concept, and this article written by, some kind of very engaged individuals within global health engagement, especially Colonel Baker, who's now retired, but now Colonel Erickson, who is our principal deputy director at our center, that this idea of engagement can happen at different levels, but ultimately we want to think about a whole of society or a whole of government approach to develop these interoperabilities. And through that, we actually demonstrate our deterrence. So if there's anyone who hasn't read this article, I would highly recommend it just to get an understanding of what the MSIW committee is working to try to develop, how medical support to irregular warfare can support that, and the resistance operating concept, specifically for part of irregular warfare that is more in the shadows and in the gray zone in terms of supporting countries that are fighting for their liberty and their ability for self-determination, and then how that partnership and how that deterrence and resiliency supports their defense against others. And so where I really start with people when talking about global health engagement at the operational and lower level is how robust is your PACE plan, right? How far down do you actually have, we understand that as you go down your PACE plan, which is your contingency plans for medical plans, right? Which is your primary, alternate, contingency, emergency plans, that the risk goes up as you go down that, but you need to have a plan. And especially in this, especially the special operations community, not having a plan or not having, options is a non-starter, right? And so there may be risks associated with different options, but we need to be thinking about these issues. And I think even from a medical, ethical, legal perspective, if we can anticipate potential ethical challenges, then we can plan our way out of them as well. And the way I really want people to think about it for NSIW is what I call the crisis conflict capability gap, which is where we're kind of set for a theater for our competition and our engagements, but then something happens, right? Like one of our ships gets bombed, in a foreign port, or there's a helicopter crash on an island outside the exercise area, right? All of these things have happened in the past. And how are we going to what are we going to do where all of a sudden the requirements far exceed what we have on the ground? And I think the way to do that gap until more resources can come, is using and leveraging and allowing our partners in many ways to help us in that area, right? So if you think of the coal bombing, if you think of some of the CV-22 crashes around Australia, I mean, you can just think of any type of large casualty generating event, whether it be a disaster or a man-made event. All of a sudden, it's a mass cal, right? And so, the whole idea of a mass cal is that the requirements exceed the resources. But if we plan well enough, maybe we can increase the resources in a time of need like that, so that the mass cow is like a little mass cow, not a big mass cow. And so I think that's really where I think we should really focus our global health engagements in, because at the end of the day, our job as a military medical system is to make sure that Americans have care. And then we can accomplish that by helping our partners make sure that their security forces have the resources they need. And so some of that is bringing back, from a knowledge management perspective, like I want to bring the concerns, the problems, the things that are discovered out in the field back to academic centers and let them chew on it. And people, we got people with field experience that are doing degrees and writing papers for programs that would love that. They want to focus on things that are real world, that really matter. And so I think there can be an increasing synergy from those that are out there doing the good work out in the field and bringing those problems and issues back to our academic centers, and people that are working on other things to help get their arms around them. So here's what I think are some of the tasks associated with medically preparing the operational environment. This is informed a lot by what we've learned in Ukraine, and especially that the work that Sakyur did with Ukraine from 2014 until 2022, and preparing them to counter, more aggression from Russia after the Crimea was annexed, before the war started. And a lot of this is just basic, you know, the things that we do with our own system, but then thinking about interoperability, thinking about how we could use systems for different uses, like using advise and assist kits to also help provide tactical level uh, telemedicine and encouragement and understanding the environment. But there is a little bit of a paradox here, is that the environment changes faster during conflict, and it's during conflict that it's harder to understand the environment. And so what can we do now before conflict starts, where environments are more permissive, just like Ukraine was before the war kicked off, so that we have the things in place, the relationships in place, the systems in place, so that we can provide support in a contested environment or a non-permissive environment. A lot of what we did in Ukraine, providing over the horizon support or across the border support using telemedicine or other video telementoring and consulting capabilities. And so I like to think of this as, what's the information we need, right? So from a knowledge management perspective, it's, and probably a lot of people here, you hear about knowledge management, you think about an IT system, but really what I want you to think about is, how do we get the right information to the right person at the right time to make the right decision, right? And understanding that health care is hard, austere healthcare is even harder. How we apply that as part of a whole of government approach to support resistance and support deterrence, I think, is important. But just knowing that at the end of it, underlying it, medicine again is a technical thing. And so I think one of the challenges that we've had over the last couple of years is we've continued to use global health engagement at the strategic level for access and placement, without a lot of focus on, okay, but what are we doing with those engagements? What are we doing at the tactical and the technical level to develop the interoperability and the capability with our partners? And so what I like to tell people too is, just like I really believe that human life has value, I also feel that our superpower, our real value in global health engagement and in our operations, is enabling our junior leaders to adapt to the situation on the ground in a way that makes the most sense, right? And this concept of mission command, I think, should apply to global health engagement, just like it should apply to MSIW and how we're working with our partners, and that we can't predict all the situations. When we send a team to do global health engagement, like, our partner gets a vote, right? They don't have the people that they think they are going to be there, or there's something's lost in translation, and the team on the ground needs to have the commander's intent enough to know, and the adaptive expertise in order to adjust and make that still of value, because they know that we're focused on interoperability. That starts with an assessment of their capability, what it is they want to be interoperable with, and understanding that the first goal of developing interoperability is agreeing to the standard by which you're going to be interoperable. And that's, I think, really one of the challenges, because the standards that we have in our system sometimes are too high for them to maintain long term. And that's why I think this consideration of including crisis standards of care in the level of care that we're providing in the context of global health engagement makes a lot of sense. And so that's kind of, if we think about mission command, commander's intent, and then enabling junior leaders to make decisions, that's what we're trying to do at NITIC at the operational tactical level, both CONUS and OCONUS. And so this is kind of our knowledge management system. I just wanted to kind of introduce that to you. We have 5 different domains. Some of it is information and like our database called Medical Options, which is focused on partner health capability assessments that are done by military people abroad so that you can find knowledge, things that you're like, we know someone's been to that hospital before. Like, why can't I find the AAR? Why can't I find the assessment, et cetera, to teaching people how to do global health engagement the best, as well as these ideas of innovation and thought leadership, et cetera. So if you're interested in that, check out our website. There's more there. But I think I just want to conclude with, how GHE supports MSIW at the operational tactical levels is one, it ties it to our strategic and policy level, right? So again, like there's a term called local in public health, which is local projects that then have global implications. And I think global health engagement is one of those. So as we try to build partner capacity to support their security forces, that is going to have potentially an impact on that whole state if, and there's different ways to approach it, but programmatically to develop capability over time that then hopefully strengthens the health system with a lot of bleed over into other areas, right? So I'll close with that and look forward to any questions.
Ramey, I heard you say a couple things, and this was a question I had in preparation for this episode. Was really basically, what does the medic need to understand? What does the medic need to understand, especially if he's doing interoperability with our allies? What does the SOIDC or the 18 Delta need to know in order to do partner development? And what I'm hearing you say is mission analysis. And that was something we got away from in the GWAT, but it comes down to mission analysis, being task specific in your output, and meaning what is the requirement. It's the requirements based. Would you agree with that
Yeah, I
comment,
would
sir?
agree with that. What I find somewhat fascinating is what people don't think is GHE. So, for example, right? So, if you listen to the Joint Trauma System conference, and they'll present a case, and there have been several that where they talk about, a partner force had a mass casualty, and they had already done rehearsals and trained their partner force medics who didn't have any medical training, right? I'm like, okay, that's global health engagement, right? Like if you get to the ground and you're like, hey, these guys don't know how to put on tourniquet. They don't have tourniquets. They don't know how to use them. This is not good. Like we need our partners to do this at the tactical level. And you do that training with them. You do the exercises, you do the rehearsals. Like that is global health engagement, right? And so people, I think, in some ways have kind of defined it as these large programs that are then defined at, are organized and trained at the higher levels. And we don't do global health engagement. We just do security operations. I'm like, well, if you're doing security operations with a partner force and you're providing healthcare together, you're doing global health engagements. You just may not realize it. And so I think, one, having that view, but also anticipating it. Like why, if you're going to deploy, why would you not think that you're going to take care of civilians, right? Why would you think that, like, show me a war where we didn't take care of some civilians somewhere, whether it be part of our outreach strategy or just as our requirement for, providing care, or maybe it's part of a humanitarian action under like responsibility to protect or something like that. So I think you have to be creative and think about, like you can say, I'm only going to take care of Americans, but then that never happens. And so the more you can be prepared, the better. And then go into it, like thinking about, so, you asked me what really got me into this area too, but what really got me interested is during my first deployment when I was a battalion surgeon in the Ghazni province in Afghanistan. This is like 07, 08. I was getting like 7 to 8 traumas like every night from that were Afghan National Army, Afghan National Police. I would stabilize them and we'd fly them up to Bagram. And I thought to myself, I'm like, what if Bagram says no? Like what if they're like, no, we can't, like, we don't have the ability to take this person anymore. What am I going to do with this patient? Right. And the answer is I'm going to send them to their own hospital. And I said, I need to go to that hospital and see what they have. And so, fortunately, we had a provincial reconstruction team with us at Gosney. And so the medical provider there and myself worked together, and we worked with our civil affairs teams, and we worked with our engineers, and we did assessments of the hospital, and we did CERP funds to build, get them equipment. We started doing weekly trauma training on the FOB, where we brought the Afghan doctors on. We built out like their emergency room. We bought them ambulances. We taught them how to do en route care. And later in that deployment, we went like a couple weeks without any casualties. And we also said, like, any casualty goes to the hospital first. And then you have to call me and and every event is a training event. Like, if we can train people in the US in hospitals, we can train your force here taking care of your people. And so they would come, and then we would take care of that patient together. And if we couldn't evac them to um, Bagram, then they would take the patient back with them, but they knew what to do. We sometimes could use CERP funds to help them give equipment or medicines, that kind of stuff. And eventually they stopped coming, like they stopped calling. And we said, like, well, what's going on? And it's like the Taliban threatening you or whatever. They're like, no, like, you taught us how to assess them. You built out our emergency room. You got us ambulances. We can hold them overnight and then drive them up to Kabul the next day. Right? It's just too dangerous to do it at night. And so we don't need you guys anymore. And I'm like, great. Like, that's what we want. And so, when I hear the JTS conferences too, it's the same kind of thing. Like, we're helping our partners by doing damage control surgery to stabilize patients, but then they're going to the local hospital. And so there have been cases where I've heard them say, like, I wish I knew what that hospital had, because that's making decisions. I'm making clinical decisions in the OR about, like, whether to do a primary repair of a vascular injury or not. And if I knew that there was a vascular surgeon there, then I would just do a temporary shunt. But I don't know, right? But that's a knowable thing. And so just walking kind of the dog as you think about your medical system, not only for you, but for your partner, and then thinking about how am I going to build this partner so that when we leave, they're not right back where they were.
Yes, sir. Hey, great. Thanks for that, Ramey. I mean, you just preempted really all the questions I had set up for you in preparation for this podcast. Um, I think this has been fantastic. Relooking old GHE, now NEDIC program and efforts, and we appreciate your time here, sir. I hope you don't mind. I want to separate from the subject. I think we've covered it extremely well, but I want to separate for the subject again and kind of use you as a test bed. We are recruiting extraordinary guests on here, yourself included. And what I want to do is just, for a little bit of development, a little bit of education, is throw a question to each one of our guests. And really, basically, it comes down to this. Ramey, sir, if your son or daughter were in the military and you wanted to provide the single greatest experience or lesson that you wanted to provide onto something that you care about that would help them in life or work, and do that in about, 3 or 4 minutes, right? What would you pass on to the audience, sir?
Yeah. Well, it's not hypothetical for me. My son, who graduated from West Point a couple of years, is an artillery officer in Hawaii right now. His wife is an intelligence officer also in Hawaii. And what I tell them is, you are there to be a critical thinker. So if something doesn't make sense, don't just assume that that's the way we should do it, right? But then also, as a critical thinker, think about, like, okay, what are the risks? What are the threats? Understanding, kind of like we talked about, the detect, prevent, respond. How can we mitigate that? So everything from, like, do we know what the electromagnetic spectrum of an artillery battery is currently? I, I don't know. I bet you there's a way to measure it, right? Or think about, like, if we know that drones are the biggest threat, what can we do now to decrease that threat, right? Same kind of thing, to prevent or respond. And this is where I think it gets to be a lot really fun. And I think that when involve your soldiers and your corpsmen and your NC, like, don't think that this all is on you. Like, like tap into the innovation and the ideas of your junior enlisted, your junior NCOs and your senior NCOs, right? I mean, I think that's where it becomes more fun, right? Which is like, okay, we're gonna have a competition for the best idea that we need to tackle as a unit, right?
Giving
About
them stewardship and ownership, right, sir?
yeah, and I think nothing is as powerful. I think of because I think I really believe that we we are the best when we enable our junior enlisted, our junior NCOs, our NCOs, and our junior officers to unleash ideas based upon the circumstances that they are facing, right? Rather than us assuming what their problems are. But if you have a good idea, there are people looking for these ideas, right?
Yes, sir.
In industry, civilian partners, even our senior leadership during SOMA and during some of our irregular warfare conferences, they talk about that. Like, don't assume that the higher levels know what the real problems are. And so that would be my idea to people whose sons and daughters are in the military is really encourage them. And then my goal to my kids who are junior officers is think big, think of problems. Don't think that no one don't assume that someone else has already thought of it. Because what I found is a lot of times no one's thought of it, or they thought of it, but they didn't do anything about it. And then involve your soldiers and the people under you, and be collaborative. I think that's the real way. And I think we really do have a leadership now that is hungry for innovation. And so I would just encourage people to share those ideas. So I know that's probably a little bit longer answer than you wanted, but and then just, that also demonstrates that you care about your soldiers. I think, thinking about what is going to hurt them and then including them in the problem solving to, plan your way out of that problem.
Sir, I appreciate that. That's good, great input, great advocacy for the next generation, most especially. Dr. Ramey Wilson, thank you for your time, your expertise, and your experience today, sir. We hope this will be of benefit to the listeners and make their work a little easier and more successful, sir. Please.
Okay, great. Thanks, Mike, and thanks to the whole committee and the podcast crew. I think this is a great effort. We lose too much knowledge over time, and so capturing these ideas, especially a lot of the other people that you've had on here, to make sure that we're not relearning things over and over. So thank you very much for that effort.
Yes, sir. Make the same mistakes only once, not repeat them. Ladies and gentlemen, thank you for your time and consideration with the global health engagement effort in NIDIC. The very best to you, to your work and families, and to our efforts in solving these very complex medical and operational challenges for irregular warfare.
Thank you for listening to this MSIW program, and we hope that you will both participate and contribute to the notes or offer thoughts, requests, and suggestions via our email link. The best to you, your work, and the relationships and security this effort strives to impact.